Good afternoon and welcome everyone to our webinar on living with a serious illness, how palliative care can help. Our presenter today is Dr. Sherika Newman. Dr. Newman is the Associate Medical Director at Vitas Healthcare Atlanta. Excuse me. She has practiced palliative medicine since 2009 in both inpatient and outpatient settings. In 2012, Dr. Newman was a nominee for the Robert Wood Johnson Leadership Award, and she worked on the Florida Physicians' Orders for Life-Sustaining Therapy, POLST. Additionally, Dr. Newman received her Doctor of Osteopathic Medicine from Nova Southeastern University College of Osteopathic Medicine. She completed her family medicine residency, followed by her fellowship in hospice and palliative medicine, both at Broward Health in Florida. Additionally, we have a panelist and Brittany Chambers, MPH, MCHES, Master of Public Health and Master of Certified Health Education Specialist, is the Director of Health Equity and Special Initiatives at the Center to Advance Palliative Care, CAPC. She leads CAPC's health equity efforts, currently managing the initiative focused on equitable access to quality palliative care for Black patients. She is the co-chair of the DEI work group for the National Coalition for Hospice and Palliative Care. In 2020, she moderated the National Academies of Sciences, Engineering, and Medicine, NASEM, Roundtable on Quality Care for People with Serious Illness webinar, Serious Illness Care, Structural Racism, and Health Disparities in the Era of COVID-19. Welcome, Dr. Newman. Welcome, Ms. Chambers. Dr. Newman, we'll begin with you. Thank you.
Thanks for having me. It's such an honor to speak with you guys today at NCBA. Such a privilege and an honor to do this, and especially with this topic that we believe is underserved and underrated in the African American Black community. And so it behooves us to, of course, get ourselves educated and empowered, especially around serious illness. Go ahead, Brittany. So what is palliative care? We have a question out there. How many of you know or have ever heard of palliative care before? We have a poll going. You should see the poll and been able to answer or respond. I would like for you guys to participate and respond to the poll questions, and chime in with questions along the way. Brittany's monitoring the chat, and we can just jump in and make this interactive, because I want you guys to take out of it everything you need and everything you wanted to come here and learn today. So have you ever heard of palliative care? So Angela says she has, but a year later, I have a yes. Good. So I'm so glad that we have some people that have heard of palliative care. Go forward, Brittany. So the definition of palliative care is long, but because it's so involved is why it's long. So it's pronounced palliative care is a specialized medical care for people who have serious illness. We can define it as cancer, heart failure, lung failure, kidney failure. All those things are considered serious illness. And this care focuses on relief of the symptoms and the stress of the serious illness, because if any of you have had yourself or a loved one that has a serious illness, it really is very stressful and can be very burdensome from a symptom standpoint for the patient and the family. And so the goal of palliative care is to improve their quality of life for both the patient and the family. Palliative care sees the patient and the patient's family as one unit, because a lot of times when a patient has a serious illness, it's the family who is there helping to provide care for this patient or being very intimately involved with the patient. So for us, it's one unit of care, both the patient and the family, which is different from most disciplines in medicine. Go ahead, Brittany. Yes, if you could just put your answers in the chat. Thank you, Angela, for saying that. Just put your answers in the chat. Palliative care is provided by a group of doctors, a specially trained group of doctors, nurses, and other specialists like social workers and chaplains that work together on a team to provide an extra layer of support. And they work alongside the patient's other doctors, whether it's your oncologist, whether it's your heart doctor, whoever is providing your care for the serious illness. We in palliative care work alongside of them. And it's appropriate for any age or any stage, meaning from the very beginning of diagnosis up until you no longer have it. We have survivorship programs for people who are cured from their serious illness. And it's provided along with your curative treatment. You don't have to stop cancer treatment or stop heart failure treatment in order to receive palliative care. They go together. Brittany? Why do you need palliative care? Why palliative care? Like I said, with a serious illness, your quality of life is completely affected. Everything about you, your symptoms, your physical body is affected, your emotional self is affected, your spiritual self is affected, and usually in a negative way. So palliative care is needed, or the why behind us is to really improve your quality of life. And there can be other medical conditions that are being treated that can also complicate your quality of life for patients that have two things, right? Like cancer and heart failure, or cancer and diabetes. So those things can complicate life to someone that's already dealing with a previous medical condition. And then what we've learned is that early intervention of palliative care, or getting palliative care as soon as you're diagnosed with a serious illness, improves patients' quality of lives, and they usually have better outcomes, meaning better overall disease processes and living longer and living higher qualities of life. Go ahead, Brittany. The key benefits of palliative care is to focus on your quality of life for the patient and the family. It's appropriate at any age or any point of your disease. Is provided with your other treatments, as we've said, alongside your other doctors, and it helps you understand what is going on and what you want. We put those together. We call them your goals of care. And so you may hear doctors talk about what's your goals of care. It's saying, hey, Miss Smith, we just told you have breast cancer, and what's the treatment? What do you want out of life? What do you expect? What do you hope happens? What do you hope improve? And then we try to match treatment with that, whether it's medical treatment, whether it's therapy, whether it's spiritual support, whatever you need to match your goals or to make your goals effective and easier, and hopefully make your goals come true. And then if something we can't do, we do have a conversation, realistic conversations about we wish it could happen. We wish you could get cured for cancer, but unfortunately, we're not in that stage of medicine yet. It is provided by a team, and it's a complete extra layer of support to help basically patients with serious illness, patients and their families navigate the road of serious illness. Go ahead, Brittany. I'm going to answer this question. Angie asks, does palliative care consist of traditional medicine or homeopathic remedies used or considered? Yes, if you're a person whose family, you and your family believe in homeopathic remedies, believe in traditional medicine, and you bring that forth to us, we will incorporate that into your treatment plan if it's realistic, or refer you out to a physician who could use homeopathic, naturopathic medicine in a good way. Public understanding. Thank you, Brittany. Public understanding of palliative care is very low. But once people are informed or educated about palliative care, over 90% said that they would consider palliative care for themselves or their family. And 94% believe patients should have access to palliative care at all of our hospitals. And 78%, and this is a poll we did at CAPC a while ago, but it's still very relevant information, but 78% strongly agree that it's important that patients and their families are educated about palliative care, and all together with the curative treatment. So not separate, but together, to learn about palliative care and the curative treatment together at the same time. Go ahead, Brittany. Palliative care and its utilization is, we have a link here with the link to CAPC that talks about palliative care for this in the serious illness for Black patients that we can provide with the slide set so that you can go check it out for yourself. Special challenges come up when people have serious illnesses. And so we have another question to ask of you because I don't know how many of you have dealt with serious illness yourself or a family member. A lot of us have dealt with it through our family members, but what special challenges have you or your family faced when a family member had serious illness? Did you guys deal with anxiety or depression? Did you or your loved one have a lot of pain, whether it's physical pain, emotional pain, nausea, trouble breathing, shortness of breath, constipation, nutritional issues? I mean, eating is a big deal for most families, especially the African-American Black community. We make up reasons to eat in our culture. And so eating and nutrition is very tough for us. It's a really serious issue when your loved one can no longer eat. Financial issues, a lot of people with serious illness go through financial struggles. I think it's people lose like most of their savings dealing with serious illness. And there's this big caregiver issue because we're in what we call the sandwich generation, where our parents are aging, but we're still working and probably sometimes still have young kids at home. And so we're not able to focus on caring for our aging loved ones or our older loved ones because we still have a full life and it is presenting a big caregiver issue. And I think COVID highlighted that more because now we also could not get to them because we were quarantined or they were quarantined. So it presented a bigger challenge for patients with serious illness. That's good, Willie. I think that's a good one. Willie is saying one of the challenges he has is making sure that we're doing right by them and having the right level of care for our patients and our loved one. And that's part of that caregiver aspect, Willie. I think sometimes what we want to do for people and how we want to help people may not be necessarily what they want for help. And that can, bump into each other. Or we all know what each other want. We're all on the same page, but we just don't have the resources or the affordability to do it. So that's a serious challenge too. Thank you for sharing that, Willie. Go ahead, Brittany. Some additional challenge is the intense emotional component, and that's what Angela just put up. Emotional issues dealing with a sibling that has long-term issues, making healthcare decisions for yourself or for another person. That is a big struggle, especially if you and your loved one or you and your family have never talked about what they would want if they were seriously ill or what they would want if they could not speak for themselves. Conflict between families, oh my God. That happens more times than not. And a lot of it is because no one has had a conversation or talked about it. A lot of times we sweep stuff under the rug or ignore or dismiss things as a family. And so we can develop conflict when it really, really gets bad or people are really sick or terminal. Feeling excluded or not part of your healthcare team. Sometimes patients have told me that specifically, a patient told me it feels like the medical team is talking at me instead of to me. And so we've been talking about how to incorporate patients in their own care and provide more patient-centered care, affording healthcare, and able to receive complex care at home. A lot of patients want to remain home, but their level of care is too high to remain home, or they don't have caregivers to allow them to remain home. So those are just some additional psychosocial challenges or social challenges that present themselves too when you have a serious illness. Go ahead, Brittany. The benefits of palliative care is that we do reduce suffering by focusing on your goals of care. Because a lot of times if you state what you want and people can give you what you want, you don't suffer. And then we help prepare families and caregivers for what to expect out of a disease, what to expect from dementia, what to expect from cancer, what we think as a medical team is going to happen in the future. And that conversation helps people plan and help people make decisions. If your doctor tells you, hey, in the future, this cancer could get worse despite medical treatment, despite chemo, if it gets worse, what would you want? It allows you to make plans, and it may not be specific. It may just be guiding posts but it gives you and affords you and your family that opportunity. And then it allows you, that plan address gaps in care. Like, yeah, I would rather be home, but I don't have anyone to care for me. It allows you to start making those plans or making those necessary adjustments. That way you don't have to come back to the hospital. There are several people, I think the last poll was in the 90s, 90% of people want to remain at home and not go back and forth to the hospital. But very few of them get that because it never talks about it. No one ever talks about it. So we can address those things in palliative care. And then it supports the caregiver's health and well-being, because caregiver support is very important. If you've ever been a caregiver, whether you're primary or secondary, it is a very hard job caring for your loved one when they're seriously ill. And so palliative care affords you the opportunity to also to get caregiver support. Go ahead, Brittany. 12 million people, over 12 million people in the United States could benefit from palliative care. That's a big number. Most of these numbers are patients that are in large hospitals, and those hospitals do have palliative care. And all you have to do, whether you're in the hospital, whether you are in your primary care doctor, a nursing home, wherever, all you have to do is ask your doctor for a palliative care consult. And they should be able to get one if the team is available. There are some areas in our nation that still don't have palliative care coverage, but that's really dwindling. I don't know the numbers, Brittany. If you know the numbers, you can put them up, but the numbers really dwindling. We really have good coverage across the nation at this point. Go forward, Brittany. How does caregiving affect caregivers? We have another poll question for you. Have you ever been a primary caregiver for a loved one or someone that was sick or close to you? And this is such a good cartoon. If I could just take a nap, if I could just nap for 30 minutes, I could make it through the rest of the day. And this is just a demonstration of sheer exhaustion that caregivers can really, really suffer from. Because as caregivers, you tend to be altruistic, you're caring for the other person, and you negate yourself a lot of the times because you really don't feel that you have the time to do it, or if you don't take care of them, something bad could happen. And so how does caregiving affect the caregiver? Go ahead, Brittany. Families are often thrust into the caregiving position, right? We don't plan for people to get sick, and there's no formal training and very little support. And so you therefore end up with increased prevalence of adverse physical, financial, social, and psychosocial outcomes because we're ill prepared to be caregivers, or we never really thought that we would end up in this position, or not at this time. You know, personally, I'm a primary caregiver for my mom, who's only 68 with full dementia. So who knew that at this time I would be a caregiver for my mom, who's relatively young. And so you're thrust into these positions when you haven't been really prepared for. You thought you had more time, you thought you had less time, whatever, you're not prepared. And then caregiver burden is a term that is used to describe this feeling, this being thrust into this position, and prevalence of physical, financial, social, and psychological outcomes. We call that caregiver burden, and that could lead to what we call caregiver burnout. Go ahead, Brittany. So what do the caregivers need? One, they need to be included as a member of the care team. When you're at the doctor's offices or at the medical clinical offices with your loved one, make sure that you are involved in the dialogue, involved in what the doctor's saying, understand what the doctor's saying. Don't feel bad about asking questions. I encourage everyone on this line to ask as many questions as you want because you're the caregiver. Jackie, oh, I get that. Jackie says she's the caregiver for her older sister that she didn't think she would have to be. And yes, women are more likely than men to be caregivers. That is very true. So the caregiver should be included in all the appointments, the conversations. And I tell the caregivers to take a notebook with you, one notebook that has all the information in it. That way, if you're not able to attend an appointment, you have to send someone else, they can go with the notebook or go with the electronic version of the information so that all the information for the patient is there. The caregiver's health, well-being, capacity, and willingness to be a caregiver is also unmet. If it's unmet, it should be addressed or assessed. If you're tired, say you're tired. If you have something that you need, state your needs so it can be addressed and assessed when you're talking to the palliative care team or any of the clinical team. And then care plans for both the patient and the caregiver should be created, and they should match each other and reflect whatever goals you have. And most importantly, it's so important to do advanced care planning. I tell people to include it when you do your financial planning, because part of the goal may not be met. And we don't come here to stay, unfortunately. All of us have to leave here. And how you leave is just as important as how you lived. So make sure that you do care plans where everyone is on the same page and we know what our sick patient or our sick loved one wants. And the caregiver needs should be addressed via referral to appropriate services, whether it's medical, whether it's disease education, community resources, online. Meals on Wheels actually has a health program now. So there are a lot of resources out there that could help caregivers, including respite needs without being on hospice. So make sure as a caregiver, you're speaking up and asking for what you need to, at the same time that you're advocating for your loved one. Go forward, Brittany. This is the funniest slide in the whole deck to me. How does the healthcare system meet these challenges? This is true, like we don't know, but we do know. No, Brittany, that was fine, go ahead. Our healthcare system really does need to do better. So we are what we call sick care. A lot of us believe that health is the absence of sickness, which is not true. And so because we have this sick focus and disease driven, we really come up short when we focus on quality of life. Outside of palliative care, most doctors aren't even trained to adequately treat symptoms or distress of serious illness, or adequately trained to have conversations about serious illness and about patients' goals and what they want. And we just need to do better as a system when we're facing patients and families with serious illness. And we're trying to do better and move this machine forward and change the mentality of the medical system. But as you can imagine, it takes time. But it's one of the charges we have at CAPC. Go ahead, Brittany. Yeah, Willie, we can speak to sundowning. That's part of dementia. So yes, at the end, Brittany, if you can remind me. It's really not that complicated, right? We have another poll question that we're gonna put out for you, but it's really not that complicated. Have you or your loved ones ever felt unheard or misunderstood by the medical team? Please just respond in the chat. Like you feel like you are being shortchanged or overlooked or not heard. So it's not that complicated to treat the disease, to maintain good health and quality of life, to coordinate care with multiple doctors, right? To have your heart doctor and your lung doctor talk to each other, or to have your cancer doctor talk to your heart doctor. It's not that difficult, and it's not that difficult to put support together to help us make informed decisions. Most of these are just conversations that need to be had, but a lot of times we fall short on the medical side because, one, the medical team's not skilled, and two, we don't always have a system where we can communicate with ease. So I see that a lot of people say, yes, they have felt misunderstood. Oh, Angie, that's true. A lot of us talk in medical terms, and it's you've done the right thing. Ask them to break it down to layman's terms. I do it sometimes too. And my family say, I don't know what you're saying. And I just say it differently. So make sure that if you don't understand what the doctor is saying, to ask them to say it differently so that you can understanding. Do not leave a medical office without an understanding. Is what I really, really encourage all of you to do. Go forward. Nope, Jacqueline, you are not alone. So don't feel alone. We all have this struggle, including me, and I'm a doctor. So other questions people ask is, when do I need palliative care? Anytime you are diagnosed with a serious illness, you or your loved one, you can get palliative care. If you have pain from a serious illness, if you have any other symptom, side effect from treatment, you can have palliative care. Any stage, any age of the disease, at any age of life and at any stage of the disease, you can have palliative care along with your other treatment. Go ahead, Brittany. What is the impact of palliative care? We're going to review some of the things we've talked about. It definitely improves your quality of life, most of the time because you're going to get what you want and not get what you don't want. It allows you to say, this is what I want, this is what I don't want. And just know that you reserve the right to change your mind. I tell my patients I wanted 4 kids and then I had 1 and I decided that's all I wanted. So I mean, you get the right to change your mind. It's your life. It also relieves pain and symptoms. It improves family support. A lot of that is around communication and dialogue. It reduces hospitalizations and emergency visits because people decide, I don't want to keep going back, or I don't want to do that anymore. How can I do something different? And it reduces unnecessary tests and procedures, like going to the ICU or having another CAT scan or having another procedure that removes fluid, any of those things. It helps. That's the impact of palliative care, all because we're just trying to meet your goals and improve your quality, you or your loved one. Go ahead, Brittany. How is palliative care paid for? It's paid through insurances, whether you have Medicare, Medicaid, or private insurances. It's similar to going to any other subspecialist, like your heart doctor or the neurologist or the pulmonologist. It's the same. We bill the same way in palliative care. Go ahead, Brittany. What is the goal of palliative care? Our goal is your goal. And the goal is to get you a good quality of life, you and your loved one, by providing the best of what medicine has to offer in terms of disease-directed treatment, meaning what's the best we have to offer for cancer care? What's the best we have to offer for heart failure? What's the best we have to offer for the complications of diabetes? And by providing the best of what palliative care has to offer in terms of symptom management and quality of life. We pair those two things together to get the patient and their loved ones the best possible quality of life. I always say we look at you as a whole person, not just Miss Smith with cancer. We look at you as Miss Smith and see what Miss Smith needs to help go through cancer, not just a person with cancer. Go ahead. Should you bring it up to the doctor or wait until the doctor brings it up to you? Brittany, go ahead and put our poll question up. It can be either or. Are you comfortable asking your doctor for questions is my question to you, or asking questions on behalf of your loved one? Please just put your response in the poll. Are you comfortable asking your doctor questions or asking questions on behalf of your loved one? So put yes or no to both of them in the poll, but it could go either way, but you should not wait on your doctor to bring it up. Some doctors still don't know about palliative care. Some don't want you to have palliative care, unfortunately. Some just feel like they can do it. A lot of different things. Don't wait to bring it up. Make sure you bring it up and ask for it. And the palliative care team are specialists. So your primary doctor must be the one to bring it in the team, right? So your primary care doctor sometimes is, if you're going through a specific serious illness treatment, the oncologist, the nephrologist, if you have kidney failure, they have to be the one to bring the palliative care team into play, but most certainly feel comfortable, ask them for it. Good, I'm glad that you guys feel comfortable. Gail says sometimes, but most of the time, no. Gail, I encourage you from this doctor that get comfortable because it's necessary for you to get what you want. And I want to empower everyone to get what they need for themselves and their loved ones. And if you feel like your doctor cannot provide that or is unwilling to provide that, then I encourage you to find someone who will. Can you request a doctor that you like or love? Yes, on the palliative care team, if you know someone that you like or love, then most certainly, Angie, you can request them. Go for it, Brittany. When and how should you ask for a referral to palliative care? If you're being treated for a serious illness and suffering from anything like uncontrolled pain, nausea, vomiting, trouble breathing, or stress from just being sick or your loved one being sick, then you should ask for a palliative care referral from your doctor. You should also explain to your doctor that you'd like a referral for extra support. And if they don't want to do it, refer them, or they don't know it, refer them to getpalliativecare.org. It has a lot of information on that website. Please write it down, or when you get the slide deck, you'll see it. But getpalliativecare.org has information for you and your loved ones. Thank you, Brittany, for putting the link in the chat. It has information for you and your loved one. It has information for doctors. It's just a wealth of information and resources to get you educated. And it can give you some lingo if you're uncomfortable having the dialogue. Go ahead, Brittany. What palliative care resources do you recommend? We do recommend getpalliativecare.org. It has the definition. It has a 5-question quiz to make sure that palliative care is right for you and gives you the information you need to talk with your doctor. It has stories of other people who've used palliative care, including people living with breast and ovarian cancer. It's a free podcast. It has directories of doctors, of palliative care providers by city, state, zip code, so you'll know what's available in your area or your loved one's area. Say you have an aunt in New Jersey who's suffering from something, put her zip code in and send it to her. A lot of times we have to kind of nudge and encourage our family in the right direction. And maybe I'll date myself, but it's okay to be a bugaboo. That's a worry wart to your family when it comes to their health. I tell families, just get slapped on the wrist, just get yelled at. It's fine, because love is just what it does. And I would rather take the hit that my family get what they need versus being quiet and seeing them suffer. So if you know someone that's even not in your area, use getpalliativecare.org to make sure they get a palliative care provider. And then download What You Should Know handout. It's very informative. It reviews the fact that palliative care is paid for by insurances. It reviews the fact of what palliative care is. It's just a quick down and dirty 1-page handout that has all of this information we're talking about that you can share with your doctor or loved ones. Brittany, go forward. Key takeaways. We're in a technology age where we really are living longer than ever before with serious illness. You know, years ago in the 20s, people died of pneumonia. The term was pneumonia is an old man's best friend. Now people can live with pneumonia, get cured from pneumonia, all kinds of things, living longer with dementia. So we're living longer with serious illness, which means we just have a different quality of life that's necessary to make sure that we're not suffering as we live longer. Patients often have complex symptoms that need to be addressed but cannot be addressed by their primary care provider. A lot of primary providers don't have the skill set to address these complex symptoms or the complex psychological needs. And even me as a palliative care doctor can't address the complex psychological needs, which is why there's a social worker on the team. Or some people have existential stress and barriers, which is why there's chaplains on the team. Because serious illness can affect a lot of areas of our lives. Both the disease and the symptoms can and should be treated, whether it's emotional, physical pain, spiritual pain. These things should be treated because they affect your outcome. If you're emotionally hurting and painful, you might not have a good outcome for your disease. It could be curable, but you make a bad decision not to get treatment because you're depressed. And so if your depression is not addressed, then you could die from an illness that could be treated. And all of that could be prevented just by dialogue with the palliative care team, by a palliative provider. Because it improves outcome for people living with serious illness, as well as their caregivers. And I had a patient that unfortunately reached over to plug in his cell phone while he was lying in bed, fell out of the bed, broke his neck, and became paralyzed. It was, as you can imagine, very traumatic for his family. To be honest, traumatic for me, because how many of us have done that, something simple, right? but he wanted to give up, and he kept telling the medical team he didn't want treatment. He wanted to come off the ventilator. They consulted me. I went in and sat down and held his hand and just talked to him about what was really bothering him, what was really hurting. And he just got into this lacklusterness about being paralyzed. So we talked about that. And I said, hey, but if that's not what you want, if you don't want to be off machines and die, don't say it. Say what you want. And I just empowered him. And his family was grateful. He was grateful. He's doing great now. They send me letters about his progress. I absolutely would love him and his family. They were such sweet people, but it was just a deep dialogue about, hey, you don't really want that. You're just sad, which is rightful because you had a trauma, but let's get you what you really want. And that's what palliative care does for a serious ill patient. We get you what you really want, because sometimes it's just hard to express. And I definitely don't want my patients dying from an emotional pain, you know? And then patients and family members can and should ask for palliative care when they need it. If you feel you need palliative care, if you take the 5-question survey on getpalliativecare.org and it says you need palliative care, please ask your primary provider for it, for you or your loved one. And be empowered to do that so that you can live a high quality life, or your loved one can live a high quality life. Go ahead, Brittany. Okay, because I talk fast, we got time to answer questions. I think there was some questions in the chat that I did not answer, Brittany. I want to make sure I address those questions. Angie, did you see some?
I know there was one question, I believe from Willie, about the sundowning, if we
Oh,
wanted
that's
to.
right. So yeah, sundowning is a term we use for mostly people that are demented or have any cognitive impairment, where they're kind of reverse. So they're up at night, usually doing all kind of foolishness, to be honest with you. They're usually, trying to get out the house, eating, roaming, not just quietly sitting, of course, and then sleeping during the day. And sundowning is best treated by medicine that would help them go to sleep at night, some type of medical treatment that would put them down at night. And then I also encourage families to keep them active during the day. No daytime naps, none of that, to keep them awake and stimulated during the day. It reminds me of a newborn baby. Brittany could probably relate to this, where, your newborn baby is also a lot of times reversed. They're up all night doing foolishness, sometimes not even crying. But the best treatment is to decrease daytime sleepiness. And then, of course, you want to make sure you have safety things in place. We've had patients that unfortunately was sundowning and got outside of the house, that was tried to cook. I had a patient that tried to cook, things like that are unsafe. So you want to make sure you put safety measures in place, latches that are high up on the door that you latch before you go to bed, or the knobs like they have for kids that kind of you can't turn. It's this extra knob on the top that's plastic where they can't grip it. Things like that, and that you put into place. I also have patients that put bells on the door so they can hear the doorbell when the patient leaves the room and stuff like that. So you want to put all those things in place. And me, myself, my mom hasn't started doing that, but I make sure I alarm the house every night. So just in case it happens, I can hear the alarm blaring. So yes, sundowning can be treated, but you have to do a combination of behavioral adjustments along with medicine. I see something else. Had this situation with my sibling, didn't know. Oh yeah. Will the palliative care team support a patient's decision to stop treatment? Oh yes, for a terminal. So I've had to do this on several occasions. Moral distress is real for clinicians as well as patients and loved ones. And a lot of times when we are under more distress, the person is under more distress, we push the patient to do something that would make us comfortable, right? So if I don't want my loved one to die, and I think that the cancer treatment is going to help them, I'll encourage them strongly. Please, 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 you just one more for me, blah, blah, blah. That's my moral distress, being displaced. And I call it displaced suffering. And so I encourage families not to displace suffering. Do not displace your suffering onto the patient. that is unkind and unfair. So don't displace suffering. If your loved one wants to stop treatment, advocate for them. I've had to do it as a physician. And I think a lot of times what I've had to tell my colleagues is stop educating them. They're not undereducated. They're not misunderstanding what you're saying. They're not people with poor intellectual property. They clearly get you. They just don't want to do it. They want a different choice. They want to be comfortable. They want to be home. They want to see their grandkid born, whatever their goal is. That is their goal, and they have a right to it. You have a right to your own goals, and they don't always have to align with what your doctors and loved ones want. So yes, I've had patients that wanted to stop treatment, and I said, hey, what you want to stop treatment? What do you want? Let's get you what you want. So please, if you have someone that wants to stop a treatment for whatever their reasons are, as long as it's not based out of a mental illness like depression, and it's their authentic wish based out of healthy decisions, then I say go for it. But always remember, even if it's based out of a healthy place, adults get to make poor decisions. And I know it's a hard pill to swallow, especially when you love someone. But adults get to make poor choices. It's part of being an adult. So if you feel like your loved one is making a poor choice, you still have to support them in that poor decision making for whatever their reason is. Some people just have had poor coping mechanisms their whole life. It's not going to go away because they have a serious illness. And so what people need in those times is just love, pure love from you as a loved one or a friend. Why is palliative care mistaken for hospice? Oh, it's like a square rectangle issue. How a rectangle is a square, but a square is not a rectangle. So palliative care is a big umbrella that means to provide comfort or quality as you're going through something serious. And hospice is a component of that. But it's just reserved for people at end of life. Hospice means you no longer want treatment, or there's no longer treatment that would be helpful for you. And that's when we provide that ultimate comfort. There are sheets that have the difference between hospice and palliative care. I think palliativecare.org has it explained, but it is a very different thing. Hospice is pure end of life care. Palliative care is not end of life. You get it as you're going through treatment for your current disorder, your current disease. And there are people who think they're the same, but they're very different, very, very different. It's even as a doctor, I've done both. Like sometimes I do palliative, sometimes I do hospice for the same company. And I swear it's like turning my head around to put on a different hat to even do the patient care. It's just very different. But just know that palliative care can be given at any age, and at any stage of your disease as you're going through treatment, where hospice is just end of life care. Do you guys see another one?
Dr. Newman, this is Angie. I have a question while as the questions come in the chat. You spoke to palliative care and us going back and requesting an appointment with our doctor if we don't get what we need. Can you speak to telemedicine? How would I go back? Do I go back and request a telemedicine appointment if I feel rushed, unheard? Is that possible? And does insurance pay for another telemedicine appointment?
Yes, so your insurance will pay for another telemedicine appointment. The one thing COVID did for us, Angie, is it brought telemedicine to the forefront of utilization. And so a lot of insurance companies and Medicare decided we have to pay for telemedicine because this pandemic has showed us we have to. So yes, the telemedicine should be paid for. And what I would do is slow my doctor down and really advocate for myself. Unfortunately, the way our insurances are set up, most doctors are under a time crunch. And those things palliative care is not under. We don't deal with time crunches. We actually see our patients in the time frame that they need it. So I would slow the doctor down. And even if it's a second visit, I would say, hey, last time we met, I didn't feel heard, and I would really want to be heard by you. And this is what I really want. I've been educated on this, or I feel strongly about this, and I really need to see a palliative care team because I feel like I'm suffering. I feel like I'm not being heard. And what I need you to do is write the referral, or what I need you to do is send me to Dr. XYZ. I found their name on getpalliativecare.org, and this is in my area. So sometimes you might have to slow your doctor down. And then the other thing, if you still feel unheard, I would write a letter, email my doctor, because a lot of times once a doctor slows down at the end of the day, they have a different mindset and they're slowed down themselves. So I would send them an email or through my patient portal and say, I really want to see a palliative care provider. I really need this in my life. I haven't had too many patients that had to really advocate hard like that. Usually the first ask, they get it, unless they have a doctor that's just challenging and they had to go through their specialist to get it.
And if I can follow up to that point, should I or should someone bring a loved one or family member with them
to the appointment?
Yes.
So I always say, if you have a serious illness, to bring someone with you, because I think, as a patient, when it's you in that hot seat, I mean, you hear so much less than what you think. It's like being in an argument with your loved one. When you're in an argument with somebody, you hear less than half of what they've said. When you're seriously ill, no, it's true. If we recorded all our arguments, I promise you would listen to it and be like, oh my God, I didn't even know they said that. But when you're seriously ill, when you're the person being treated, you really don't hear all of what the doctor is saying because you have that emotional thing going on in the background. And so having your loved one there to take notes, to hear with you, to see with you, makes a world of a difference. And they can advocate for you if you miss something. So, I was telling Brittany and Angie and them that my son, my adult child, by the way, recently went to the hospital and I was on the phone advocating for him, and his phone died and he left the hospital without getting what he needed. And as his mother, I was extremely vexed. Livid, I would say, more than vexed. And I made sure that when he went back to the hospital, because I sent him back, that he took his girlfriend with him, because obviously you don't know how to advocate for yourself, and she does. So it is important that you have someone that advocates for you. And I always recommend that advocacy be assertive and not aggressive, because aggression can shut the medical team down. It can mislabel you as a difficult patient, difficult family, but you do want to be assertive in your advocation. You do want to politely say, no, this is what I need. This is what I need for you to do. And I understand if you can't do it, who can in your system? Do I need to talk with the supervisor? Is there a way I can talk with the administrator? Because I really do need this. And it's okay if you can't do it, but someone in this system or someone in this company or institution must be able to do it. So it's make sure that when you're advocating, whether it's for yourself or your loved one, that you're assertive but not aggressive.
Okay. And then I'm going to invite our audience to ask questions and wait for those questions to come in. And I'm going to ask my follow-up question. Dr. Newman, you spoke to clergy being involved in palliative care treatment. Can I invite my clergy to be a part of that care team, or? Okay.
Your community clergy and community provider can be a part of your team. Anyone you want can be a part of your care team.
And insurance will pay for that person to be a part of my care team.
Insurance won't pay for the clergy, your community clergy to be a part of it, but your community clergy can definitely be a part of your advocacy and speak for you and speak to the spiritual component of your life that plays a part in your treatment plan. And I encourage people to do that, whatever your clergy is, whatever your faith base is. If you have a high faith base and it's part of your decision making, part of your goals, part of who you are, make sure you incorporate that into your medical care. If you believe in miracles, make sure you incorporate that. Because I always ask my patients, like, what does that look like for you? Because what I believe in a miracle, what you believe may be different. So let's talk about it to get on the same page so I can see what it looks like for you and how that out pictures. If you believe in prayer at XYZ time, what does that look like? How can we make sure that happens if you're ever hospitalized, right? I have plenty of Islamic patients who are who pray 5 times a day, right? So I want to make sure that you're still doing that. How can we do that for you? So you can bring your community people into it. Insurance won't pay for it, but it's a very strong advocacy for you, especially to me in our Black community. Churches are very, very integral part of our culture. It helps with our interconnectedness, which is very important when you have a serious illness. I think that a lot of the interconnectedness is being lost and finally being reborn after this pandemic, because we really saw the suffering of the lack of interconnectedness among families or community. And I think churches help provide, or religious and faith-based organizations help provide that interconnectedness, especially for patients or people that may be migrants from their family. Like all of my family is in Florida, but I'm in Georgia, right? So I'm here kind of by myself, but my faith-based community provides me that interconnectedness. So yeah, if I got sick, knock on wood, pray to God I don't, but if I did, my faith-based community would show up at the hospital. And so it's important that you incorporate them into your care team if that's your comfort. But you can have anyone as a part of your care team or advocating for you. Don't let a provider say they can't be here or it's not allowed. That's not true. As long as you give permission, it's allowed. And as long as you're okay with them hearing your protected health information, it's perfectly fine.
Thank you, Dr. Newman. And I'd like to ask you if we can use the next few minutes to just talk a little bit about how we get our families on board with this conversation. I know in the African American community, just talking about estate planning and talking about our next wills and so forth, and advanced directives and all these terms. I mean, they mean so much, but how do we start this conversation when they're so still and remain so taboo? What is your advice?
Oh my God, that's such a good question, Angie. I might not have the best advice. I'm just a bugaboo. So I just keep talking about it with my family. At family gatherings, I talk about it. I usually start off with a story or something funny. I'll, like if we're eating at a family gathering, I'll say, hey, y'all know I love macaroni and cheese. If I ever get to a point where I cannot eat macaroni and cheese, y'all gonna have to blend this down in the blender and put in my feeding tube, right? I'll usually start off with something like that. And then I'll say, oh no, but I don't want a feeding tube. Just for real, I don't ever want a feeding tube if it can't be taken out. Like I'll start it up like that. And then I'll usually punt the question to someone else. Like, what do you think? Would you want a feeding tube? Blah, blah. So I usually start funny like that. But when it's time, like if someone actually has a serious illness, I actually put together a family meeting and bring my family together. And there are some resources out there. One is called the Conversation Project. It has a starter kit. Brittany, if you could put the link to the Conversation Project starter kit up. So it has a link to the Conversation Project, and that has information about the importance of talking about serious illness, talking about what I want if I couldn't speak up for myself, what I want at end of life. It has all of that conversation that we're afraid to talk about, that's taboo. But then what it does that I absolutely love is gives you questions to pose. Because a lot of times we just don't even know how to ask it. If it's not like Thanksgiving dinner conversation, you know? So you just don't know how to ask the question. So the Conversation Project gives you the question to kind of say, hey, mom, hey, dad, if this ever happens, what would you want? It gives you those questions. And then it has a way to keep the dialogue going. It shows you how to just keep the dialogue going. And I always remind people that this is a process, not an event. It isn't that you're going to sit down one day at the table and write it all out. That's not how it works. It's an ongoing process. And if it gets too tough, stop, pause, take a break. Hey, I'm getting too emotional. This is too hard. Can we take the time out? Or you can say to your loved one, hey, it looks like it's getting a little bit too much for you. Want to take a break? And then we'll pick this back up tomorrow, next week, whatever the time frame. Take the break, but give a time frame. Don't leave it open, because if you leave it open, they'll never come back. So make sure you give a time frame. Do you want to check back in next week? Blah, blah, blah. We can pick it back up. I'll give you some more time to think about it. But I don't let it go. I usually just come back around to it, and it is uncomfortable it's never going to be comfortable. And I tell my loved ones that this is uncomfortable. It's never going to be comfortable. There's never a right time. It doesn't work like that. But it's such an important conversation that you just have to have it. And I like having it before anyone ever gets sick. And then what I do, Angie, is if someone gets sick, I'll come back around to them. Like I had this conversation a long time ago with my mom kicking and screaming. And then as the dementia started kicking in, I went back to her before she really lost her memory and said, hey, is this still what you want? Would you want to do this? Would you want to do with this? So I made sure I went back and reviewed it with her. But I think you just have to kind of stay on your loved one without being too aggressive or too bugging, but just kind of say, you know, I love you and this really needs to get done. And it's so important for me because I want to make sure that you get what you want. If you can't talk for yourself, I want to make sure that I'm still advocating for you in the right way that you would want it. And the truth is, all of us love our autonomy. We love our independence, and we want to have our independence even when we can't speak for ourselves. And the only way to do that is to have someone surrogate for you, to have someone doing it for you. And so you have to have the dialogue so that someone's comfortably doing it for you. So I say just stay persistent without being nagging.
Okay, thank you.
The other tool I use is I'll find the card deck and send it to you guys, Angie. It's a card deck where you have your loved ones pick out 10 things that's very important to them. It has different phrases there. They have it online and they have it physically. So you have them pick out 10 things that is very important to them. And you start the conversation like that, like being able to, like I had a patient who said was very important is still being able to sit up under this pecan tree, right? So then it creates a dialogue for the family. How would we get that for him if he became paralyzed, or how would we do it, blah, blah, blah. You know, so it creates the dialogue. And what I've come to realize is that most of the time families want the same thing. They're saying it differently, but what they want organically is the same thing for themselves and their loved one. It's just that one sister wants to do it this way and the other sister wants to do it this way. And it's just how it out pictures may be different, but the fundamental thing is the same. So it's just getting everyone on the same page. And that game, it's a card game. I got to think of the name. I got it in one of these purses. I'll make sure I get it over to you guys.
Okay, thank you, Dr. Newman. And we have one question and time for one more question, if it's okay with you.
Oh, yeah.
Okay, so it reads, you mentioned get permission to add faith-based community advocate to your app.
Appointment
From who?
What I mean by get permission is if your local faith-based clergy want to participate, they can come to the appointment and you just let the doctor know, I've given this person permission to be a part of this appointment and they can hear all of my information. So it's not necessarily get permission per se, like to check in with somebody. The appointment, whether it's telemedicine or whatever, and then let the doctor and the clinical team know that they are part of your care team and you've given them permission. You have given them permission to participate.
Dr. Newman, it is 1:58. We have 2 minutes for questions. If our audience would like to ask.
Go Wish. I'm sorry. Thank you, Brittany. Go Wish is the name of the one I was talking about. Thank you, Brittany. Oh.
Thank you, Brittany. Thank you, Brittany.
Put it in the chat.
Thank you. And if our audience has any additional questions, we have 2 minutes.
2 minutes.
2 minutes.
And if you think of questions afterwards, audience, please email Angie, email me. They'll get them to me. I'll respond to you because having you educated and empowered is very, very important to me. So get us your questions. If you think of something, or if you go talking with your family and they come up with the question, get your questions over to us.
Dr. Newman, I'm going to talk to my family. This is going to be not an easy conversation. I can hear my father screaming now, but I'm going to do it. And I'm going to let you know how it turns out.
Let me know. And if you get stuck, Angie, let me know. I'll give you some tricks.
Okay, thank you very much. And let's see, do we have any other questions? Well, we don't, and we are at 2 o'clock. So
Thank
Dr.
you guys for having me.
You are awesome, awesome, awesome. We hope to see you in Washington, D.C. soon. Thank you for joining us. We hope you will come back. thank you, Brittany, very much for educating us. We hope that you will join us, and we just appreciate everything you do for our families, and thank you.
You're welcome.
Thank you.
Thank
Have a
you.
great day, everyone.
Thank you, everyone. Bye-bye.